It's my pleasure to welcome Dr. Daubney Boland, who's our presenter this evening. Dr. Boland is a licensed psychologist and prescriber in southern New Mexico. She graduated from New Mexico State University with her master's in clinical mental health, a PhD in counseling psychology, and an MS in clinical psychopharmacology. Very impressive. She practiced in primary care in medical settings for the past 14 years and provided psychological care for individuals across the lifespan. She worked as a clinician and behavioral science faculty at the Southern New Mexico Family Medicine Residency Program and was adjunct faculty at New Mexico State University. She works currently as a clinician at iNet Med and provides integrated psychotherapy and medication management and partners with other medical providers to provide gender-affirming care in Southern New Mexico. So, Dr. Boland, thank you so much for joining, and I will give you the floor.
Thank you so much. Okay, so gender affirming care. I should say, that I think the goals of this presentation is really trying to build your understanding and look for maybe some blind spots that you have. And hopefully this is just another aspect of learning. This is not the be all end all to gender affirming care. It's really more like paying attention to blind spots, recognizing some blind spots that you might already have, and then hopefully engaging and encouraging you to investigate further. I don't have any conflicts of interest, and I'm not an expert. I'll tell you, Las Cruces is somewhat of a rural area. Even though it's the second largest city in New Mexico, we only have about 100,000 people. And so we are considered a health care provider shortage area. And what we've seen is just there's this really big gap in care. And so I find myself doing more and more gender affirming care. And as part of CE committee for a state organization, I offered some of these presentations and worked with colleagues to increase my knowledge and understanding. So I really am not an expert. I don't pretend to be an expert, but I'll share what I've learned and hopefully some room for growth. I have to include these objectives, describe at least 2 ways transgender or non-binary youth are at risk, identify at least 2 steps providers can take. This one is important. What things can you do differently, right? How can you improve the care, gender affirming care at your place of practice? And then identify, since this is psychopharm, at least 2 pharmacotherapy interventions in trans care. I like videos. I think sometimes it can capture our attention a little bit better, especially if you're more distracted or you're trying to offer trainings to others. So these are just pretty brief videos that you can use in your practice, whether you're training other healthcare providers, if you're working with a family that is really trying to understand either gender pronouns and what gender affirming care looks like. So these are just some samples that I've chosen that I really like. I think the most important thing to understand about terminology is to understand how your client defines themselves. The most important thing is actually to talk with your patient about what language they prefer, what are their pronouns, how do they describe their gender. Ask them to kind of identify for themselves, and then I sometimes have them describe what they think that means, because a lot of times we make assumptions based on what a word sounds like, and then I find out, oh, their definition might be a little bit different than mine. And what's important? I want to understand where they're coming from, right? So I think what's most important is that you're asking your client what pronouns they prefer, how they would describe their sex and gender. Here's an example of gender pronouns that I think are helpful. They, them, theirs, themselves is really becoming more and more common. So I think it's really important that you get more familiar with that. You can see Z, you might actually see XE, XI, as well as Z. Again, you're kind of gathering that from your client as well. Felicia, you have a really good point. I often slip up with pronouns, though I respect everyone's right to have whatever pronouns they have. Do you have any suggestions on how I can bridge that gap with people and let them know I might make mistakes? I say that at the beginning, right? So I'll ask them, do they have preferred pronouns? I want to make sure that I honor that. There might be a time that I mess that up and I just want to apologize in advance. One thing that I can do to try and make that better is make a note to myself or put a message in the chart so that I can help other team members also do that as well. But the more straightforward, you're going to make mistakes. You're going to make mistakes. And the article I really wanted us to look at talks about that. Like, you're going to make mistakes, but the fact that you are trying and the fact that you are showing respect and you're being inclusive makes all the difference. So I think you're all right to say, I'm going to make mistakes. I want to respect you and make sure that I'm doing what you prefer. Fatima also mentioned that you asked to clarify, right, and often start with neutral pronouns too. So I sometimes have people introduce themselves and kind of think about that a little bit. Okay, so this first case is really just asking you to think about where you work. Roy is a transgender male presenting in your clinic for the treatment of depression. How comfortable do you already feel seeing Roy in your clinic? What pronouns would you use? What barriers do you think Roy might have faced before coming to your clinic? And also, what barriers might present themselves at your own clinic? And even thinking about the structure where you work, what kinds of things do you think Roy might bump up against? Microaggressive comments, right? I think this comes from unconscious bias and actual bias, right? That sometimes we're not really mindful of the way we talk from the front staff to the back. How much training have each of us had? I think that that's a big one. Insurance. Ooh, sex assigned at birth. Absolutely. Roy probably has had some bad experiences with healthcare providers. Yeah, that's probably true. Right. And then how many times do we misgender? How many times do we use the wrong pronoun? From the front to the back. What kinds of things did Roy already experience? Hopefully you're asking what pronouns he prefers. Sorry, I'm using he because those are his pronouns, he, him. Also thinking about what other people Roy encounters in your office, in your clinic. I think that that's super important. So I'll actually go up to my medical assistants and I'll give them the verbal. This is how I'd like you to approach Roy, or these are Roy's pronouns. I put it in the chart. My front staff is getting better, I think, and just a little gentle reminding. Um, and and it goes a lot better. Not making assumptions about what Roy's gender is. You ask. Yeah, provider's not an island. How many other people did Roy have to interact just to get to you? I'm going to give a case later with Silver, and he saw multiple providers and multiple clinics, and it just wasn't good. So really, this is like one of the most marginalized groups in the United States. Trans individuals in particular, and trans women of color are at the highest rate of violence against them. We see high rates of suicide, of severe depression, and psychological illness. And I think a lot of it is in part because of all the stigma and discrimination that individuals face. I think the big thing we have to understand is there is a lot of violence and stress. How many of you remember the minority stress model? This was adapted to include gender minority stress. And so it's not just about an individual in one environment, right? We really need to think about the layers that this is impacting. So what is our political climate right now for our conversations about gender, our conversations about being transgender, and how does that impact our youth? How does that impact our loved ones? This picture really looks at how gender-related discrimination can impact physical and mental health outcomes. And then gender-related rejection can have negative experiences and negative expectations hiding. So I have quite a few folks who have transitioned and they have not told anyone that they've transitioned. And I think Las Cruces is a pretty supportive environment, but they're coming from other areas maybe where it was not safe to disclose. And so there is a lot of concealment even after transitioning, victimization related to gender, and then not affirming their identity. And so some protective factors can be their own pride in their gender and community connectedness. I'll go into this a little bit more in detail, but in treatment, I'm always thinking about how can I increase social support, positive social support. What does that social support look like? How can I beef that up? Because community connectedness, I think, is super, super important. So this just kind of goes into the model a little bit more in detail, things that kind of help include that or boost that resilience. And resilience, I struggle with a bit because it's kind of that bootstraps mentality. And I feel like not everyone has a pair of boots, but I do think it's important to think about context and different aspects of support that can be really empowering and supporting. And I can give you examples of the difference between my teens who have parental and family support versus those that don't. And I feel like that could be in a discussion all of its own. And the challenges that come from hiding and not feeling safe to be out and what that does internally. So this kind of goes into anyway certain resilience factors as well as interventions, community interventions as well as individual interventions in mental health. I do love the Trevor Project, and it's definitely a place that I donate regularly. And some of their funding was cut recently. I don't know if you follow any of that, but definitely a good one. This is a little bit outdated, but this is gender affirming care in New Mexico. So this is based off of what was brought forward in 2023. And again, I think New Mexico is pretty awesome. You know, you can qualify for quite a few surgeries through Medicaid in New Mexico. Gender affirming care is actually written into both House and Senate bills. So that's cool and important because we neighbor Texas, which often does the opposite. And in fact, we have folks who travel across state lines for healthcare and they have to be really careful in parts of Texas. All right, so Silver's story. Silver is a 15-year-old transgender male teenager who's being seen at a mental health clinic. He's being treated for MDD, major depressive disorder, pretty severe. When I saw him, he had been just recently discharged from inpatient. He was engaging in restrictive eating and purging. He had a diagnosis of gender dysphoria and was engaging in some pretty serious self-harm. He was on ziprasidone, Abilify, and duloxetine. I think he is on the Geodon, the ziprasidone, and the Abilify together as a cross titration. He was getting off of Abilify and starting onto ziprasidone. So he was seeing a prescribing psychologist as well as a therapist. And his current therapist who referred him to me was concerned that, you know, he just wasn't stable enough for affirming hormone therapy. And so his therapist was sending him to me to say, hey, you know, he needs some guidance. He needs to be stabilized before we can start the hormone therapy. Any thoughts about Silver? Joy?
I'm an eating disorder specialist and I own a group practice and I also do a lot of surgery affirmation letters. And this is something we see all the time that people are like, they're not stable enough because they're engaged in eating disorder behaviors. And though it's not a hard rule, many of my clients who are engaged in behaviors are doing so to manipulate their body to better represent the gender that they feel. So it's kind of silly because we're like, well, if you did these things, we might see a reduction in behaviors.
And that's what he needed. He needed people to hear what was going on. And so sure enough, you know, once we were able to start the hormone therapy, you know, I think he's on 20 milligrams fluoxetine and the cutting has pretty much gone away and the eating disorder has resolved. We just weren't listening, right? We weren't listening to what was going on for him. So what's happening here is there's anxiety of not understanding, right? His healthcare providers don't know enough, are uncomfortable, so they're delaying care. And parents are bored. So it's not the parents, it's not the family, it's not the kiddo. You know, he's really good at being clear about what he needs, I think. There was a lot of anxiety and delay in getting his care. So he moved on to hormone therapy. We did do the education around starting testosterone and we did some CBT and self-acceptance work and you know, he's doing great. So he's been on testosterone for a bit now and he's doing amazing. And I would say that his story was really impactful for me and part of why I wanted to do the presentation because we were just harming him by not treating. If you are providing gender affirming care, it is helpful to include gender dysphoria if you think that they want to have hormone therapy or any kind of surgery. There is some anxiety about documenting that in their chart. I think there's a lot of uproar with some political concerns, I think, and protecting, you know, concealing identities. But just know that you're not going to be able to get some of those things approved if you don't have that diagnosis of gender dysphoria. And I really kind of hate it in some ways because I think not everyone experiences dysphoria. And I think for younger folks, when they have a good support system, they don't experience dysphoria. They just experience gender in the way they do, the way that they express it, the way they feel their body is, and they have support around them to support that. So gender dysphoria is kind of one of those DSM, ICD things that we have to deal with. I cover letter writing in this presentation and the WPATH letters of support, and WPATH does include recommendations. But what's more important is that you have your person identify where they're having the surgery, and that agency will have a list of recommendations that you need to follow. So you don't necessarily have to follow the WPATH, but I go off the checklist I get from the surgeon. This is a really important comment. Okay, A lot of people, more than 75% of people who report gender dysphoria are not seeking surgery. A lot of people are not seeking surgery. It's important that you know how to support your patient if that's what they want and need. But I think there's a lot of anxiety there, and I just want to say, a lot of people don't even want that. So we'll go through this case real quick as a more of a like an education point. So, Ren is a 10-year-old child, sex assigned at birth as female, identified as male, previously identified as gender nonconforming. Patient started menstruating at age 9, which is not fun, just not fun. Family had an aversion to birth control. They didn't want to put Ren, on birth control at age 9. But patient would like to avoid having periods for the purpose of gender identity affirmation. Patient has previous diagnosis of pediatric bipolar disorder, presents to your clinic for assistance in getting mood under control and seeking birth control to stop having periods and feel more like himself. So, any cautions, recommendations for the patient and family? I think this was a tough case because one, Ren had a really disjointed family, and birth mom was very uncomfortable, not okay with anything that was gender affirming. And grandmother, who was primary caregiver, was like, I don't, I just need my kid to be the mood to be a little bit more regulated. So it was really kind of complicated. In this case, there was a lot of education to the family. Birth control is a little bit more benign. You could at least look at kind of stopping menses for a little bit and seeing if there's some better mood management and if patient feels a little less dysphoric during their cycle. But it was definitely kind of a continued discussion with kiddo and with grandmother to kind of give it a shot. This was definitely I think it is more challenging when you have a minor whose family's not on board. We're getting to the nuts and bolts here. What does treatment look like? And I think when we gave the very first example of Roy, I asked you to think about what is it like to walk into your clinic? There are so many layers to treatment. It's not about the surgery. It's about all the little microaggressions that take place every day, like 1,000 tiny paper cuts. And so I really want you to think about all the aspects in treatment, right? And I could even expand this bigger to like community, right? So community of Las Cruces and what is New Mexico doing and what is the United States doing, all those pieces, but really trying to understand not just the individual, but the context in which that person really lives. To ask yourself, do you have any recommendations or guidelines for the providers in your clinic? What does your waiting room look like, or your bathrooms, your staff? Have your staff gone through any specific training that was helpful? What does your electronic health record look like? How can we add certain things in, like preferred name, pronouns, things that kind of help us track and make sure that we're being responsive to our patients' needs and that we're not misgendering them, we're not using their dead name, things that can be really, really overwhelming for a person. We haven't gotten into the mental health treatment yet, but I want to just like make this kind of clear. A lot of our gender affirming patients have experienced trauma, significant trauma, whether that's sexual trauma, violence, discrimination for their gender identity. We really need to do our best to be mindful and kind. And so train up your staff if you can. It's my little soapbox. I apologize, but I'm going to keep getting on it. So medical care can look different depending on what your patient needs. If you are a provider who's offering gender affirming care, if you're a provider who's asking open-ended questions and offering some support and guidance, especially among your teens, people will have questions. Your client may have some questions. I'm not sure what I do, or where do I go, or who do I talk to? So it's helpful to have some information, right? Some knowledge, and then being able to refer them to other folks who might be even more knowledgeable. So medical care can include hormone therapy. That's probably the primary form of treatment. Not everyone who's gender dysphoric is trans. Okay. So these interventions may or may not be necessary. You just need to kind of do the work to find out what your patient needs and is asking for. Hormone therapies are about as safe as most medical treatment, most medications. They all come with the good and the bad. So kind of being mindful of that. And this is often done, your primary care provider can do it. For pediatrics, you might send them to an endocrinologist. but it doesn't have to be. Medical procedures can include a number of different types of surgeries. Top half surgery and facial feminization, those surgeries are a lot easier covered. When you're talking about a vaginoplasty or something to that nature, that is much harder to get approved. And so you'll have to do your homework and work with your client considerably on that piece. All right. Masculinizing. Those hormone therapies are going to promote facial hair and body hair, the deepening of your voice. So you can gain weight on them. So just, if somebody has a past history of an eating disorder or body dysmorphia, just gonna, make sure you're talking about that. But increased muscle mass, so the opportunity to be bigger, bulkier. And feminizing treatments are gonna have breast development, redistribution of fat, and skin softening. Yeah, so there's just some common things that you might see. You want to make sure that you're, continuing to engage your patient in decision making, shared decision making, that they are getting their questions answered. And maybe you're not the right person to answer some of those questions, but maybe you can help connect them. But I do think I've learned a lot, and I'm also trained to communicate, right? So sometimes I'm a translator for my other healthcare team members. They'll come back from seeing their endocrinologist, and I'm like, okay, so you understand the risks of, what we talked about, fertility. And they're like, wait, what? So sometimes as a psychologist, I'm translating. I'm saying, okay, what parts do you understand, and where is it still gray? And are we still on board for this? And I might be doing that with parents, or I might be, adults can make their own decisions. Depending on who I'm working with, I might be really trying to understand and uncover what they know, what they don't know, what of the risks and benefits, and what they're looking for. So here is where I see a lot of people's anxiety. So hormone therapy really is recommended at Tanner stage 2 in puberty. So for Tanner stage, you see this like budding, the breast budding, and just the beginning of some pubic hair born at birth, female. And then for folks who are wanting feminization care, again, that would be Tanner stage 2. So there's a little bit of that pubic hair and kind of beginning reddening of the scrotum. Again, specific, but thickening or reddening of the scrotum is kind of like getting a little bit bigger. So this is young, right? So for kids who are going through menses at age 9, that feels really scary to a lot of people. And so I feel like a lot of the discussions are like, I'm okay with my kid expressing themselves, but I'm not cool with medical interventions. Or I'll be cool with some medical interventions in high school. So a lot of times what you see is those surgeries aren't really happening until adulthood, 18 plus. And a lot of times they're very difficult to get them approved surgery wise without parent consent. There's a lot of gatekeeping there. And I get it. You're trusting your kid to understand themselves, and it's confusing. I mean, puberty is confusing, right? I don't know if any of you have any thoughts or reaction to this, but it is pretty early on that to see the best interventions, most effective interventions is early on in puberty. One of the biggest things about estrogen-based treatments, think about how many people are on any kind of estrogen-based birth control or hormone therapy for menopause, or, it's not just gender-affirming care. Estrogen increases your risk for blood clots. I don't know if you've been told that. So we do advise recommendation of quitting smoking if possible. So the question is, does fat distribution work similarly with testosterone and estrogen? Where the fat is distributed is different. So with testosterone, you might see overall body mass, whereas with estrogen, you're going to see like it in the hip area, breast area. Okay, so in terms of feminizing hormones, androgen reducing agents. So the ones that I see the most is spironolactone, which people use spironolactone for a lot of different things. The big one I look at is monitoring their blood pressure. And then also you want to kind of take a glance at their potassium electrolytes every now and again. I have a patient who's been on spironolactone for a long time, even though this person is very tall, um, and heavier set, their blood pressure is very low. So I do monitor that every time they come in. And then the other ones I see a lot are the 5-alpha reductase inhibitors, so finasteride and dulasteride. So these are really helpful for hair loss. in New Mexico, at least, most insurances will not cover hair removal. I have some really hairy folks, and it's really distressing. It's really, really distressing, unfortunately. So I think the finasteride can be helpful in hair thinning. Progesterone is really not used that much, and I think partly it's not as effective as we think it is. And there's some weight gain and some other things we kind of watch for. So the big one I would say is the spironolactone, and then your hair thinning. Masculinizing hormone therapy. The two biggest ones I see are testosterone and then treatment to stop menses. So like Nexplanon. Those are probably the biggest. So again, the goal is deepening of the voice, development of facial hair. People get so excited when that beard comes in. I just like, oh my gosh. And when the voice gets lower, oh my goodness. You get to see some happy people when that dysphoria goes away and they feel like more in line with their gender. It's just super cool. Testosterone blockers do not impact facial hair for trans women. I have to think about that. I think that there can be some benefit. Yes, testosterone blockers with facial hair, because I'm not a physician, okay, but thinning. The hair is thinner when you have those testosterone blockers. It's not as coarse. And if a patient who was male at birth was diabetic, they may have trouble regulating their diabetes after starting hormone therapy when transition to female. Different responses to diabetic treatment. So are you concerned about like estrogen-based hormone therapy in terms of being diabetic, or fat distribution? What is your concern about being diabetic? They don't respond to diabetic meds. Do you mean like they're more insulin resistant? Okay. So maybe if they're type 1 diabetic, we might be monitoring that a little more differently. I have definitely lots of patients on metformin and the GLP-1s that they do just fine, but that is something to think about. Right. So you are not doing this by yourself, right? You're using your team, and hopefully that is, other healthcare providers who can do their regular treatments, right? They're still doing their typical lab work and treating their other conditions. So yeah, you might modify a little bit, right? Like, so I have a patient with low blood pressure. Maybe spironolactone is not the right treatment. You use certain estrogens and your patient is having a harder time with their insulin absorption. So you might modify that, yeah. What does a clinical team typically look like? I think it depends. I have a buddy who was working at a gender-affirming clinic. So she had a huge team, voice feminization and speech therapists and physical therapists, counseling, mental health, surgeons. For me, I am in a mental health clinic by my lonesome, but I got buddies in the community. So I have a couple of primary care providers that I work with and love to death, and we'll do our monthly check-in and kind of review how people are doing. So I'd say you can do it with bare bones, but it is helpful to have a bigger team. So endocrinology, primary care, pediatrician, maybe you're working with somebody from their insurance, like a case manager, family members, those folks. Your patient should be at the forefront of your team. So one thing I'll say is menses can be really dysphoric, not even for people with gender dysphoria. Having a period is not fun for a lot of people. And so for some teens, on some adults, just being able to alleviate their menstrual cycle is enough. You don't see that PMDD, those mood swings right before the cycle, and then you don't have this dysphoria when you're dealing with, this yucky thing. So this is where it's really helpful to explore what it is that your client is looking for and needing. And especially if family members are involved or there's a lot of anxiety about what gender-affirming care can look like, if you're doing the whys, if you're exploring what they're really needing, you might come up with some pretty simple solutions without a lot of risk. Again, testosterone is used in other treatments. It's not just for gender-affirming care. And so you do have to monitor blood pressure and electrolytes. You have to watch their A1C. The other one that's a little bit weird is monitoring for polycythemia. So this, again, is a little bit more risk about testosterone. Yeah, interesting about the estrogens. I hadn't really thought about estrogen impacting type 2 diabetes. I saw that more with testosterone. So I'll kind of think about that. Male pattern baldness is real. So you might see that hair thinning. Informed consent, I think, is really, really big, because even at the hormone therapy level, there are some risks that are irreversible, right? Testosterone is a pretty significant treatment, so you need to be thinking about what your clients' is or goals about family look like. Are they going to want to have children, their own children? Are they interested in any of these options in terms of egg freezing, embryo freezing? These are really expensive and they're not covered by your insurance. So these are things to like, I feel this is a discussion for some who are more privileged. But, so we've had conversations about adoption and whether or not they think they want to have a family or start a family. And I think for quite a few folks who've experienced a lot of trauma, there's like, nope, nope, no, I'm not having my own children. But that's not always the case. So you really need to kind of talk about that. And maybe that changes the treatment that they decide. Okay, so we'll talk about Ty real quick. So Ty is a 22-year-old trans male, past medical history of anxiety, here to establish care. He's already been on gender-affirming hormone therapy, testosterone. He's doing the injection weekly. By the way, this is where you work with your healthcare team because you can modify that dose. And as you've been on testosterone longer, you can actually reduce your dose or increase the frequency of time between doses, all that kind of stuff. So he's coming in to see you. He thinks he's doing pretty well, no concerns, but his lab work comes back and his hemoglobin is 19. The high range is kind of in the 15 area, and his hematocrit of 55, which is again above range. Any ideas? Polycythemia, which, one really cool thing about polycythemia. So one of my primary care docs, family medicine docs, is like, just have them go donate blood. Cool. So they'll monitor every 3 to 6 months, and if polycythemia is kind of creeping up, they'll go have them donate blood. And there it is. It's kind of able to monitor that a little bit. I have seen, so the frequency of lab monitoring depends on where they are in their hormone therapy. So if they're newer to the medication, you're going to monitor more frequently. If they've been on the medication for several years, you can push that out. I have somebody who goes in like annually, but sees me more regularly, so we can kind of keep an eye on things. It's impossible to remember all the drug interactions. I'm sorry. I am smart, but I am not that smart. I don't know how many of you are hoping to do the RxP, the Masters in Psychopharmacology. Anytime my patient changes their medicine, I do a drug interaction check. I'm sorry. I don't know it all, and things are always changing. So even medications that I used years ago have new indications. So I love Hippocrates. It's free. And then there's a provider version that's not very expensive. And I do a med reconciliation, so I'm asking my patients about what they're taking at every visit. Anytime I know they're going to go see their primary care provider, one of their specialists, their rheumatologist, whoever, I'm like, hey, did your medications change by any chance? And then on my EHR, my electronic health record, I have this really cool tool where I can click and see whatever medicine was sent to their pharmacy, which is really awesome because people forget what they're taking. Oh, I'm on this new blood pressure medicine. Oh, I want this or that. I'm like, okay, let's go look it up. Is this right? Okay, what are you taking this for? And then I do my little interaction check. There are a couple of clinics here in town that have a pharmacist in their primary care clinic. I love that. If not, there are a couple of pharmacists that I will kind of refer people to because I'm not a pharmacist, but I'm like, those two don't sound great together. I'm thinking in my head, I might refer you back to the pharmacist for some education and recommendations. I do remember some of the big ones, right? But I'm still going to run that interaction check and just make sure. The other thoughts or questions? IVF may be an insurance benefit in the next year or so. Okay. Well, that would be definitely regional. I don't know when New Mexico will get something like that, but that would be cool. And I do know a lot of my patients do travel out of state for surgery, California, Massachusetts. That is helpful to know. So a lot of the medical benefits, I think, are about dysphoria, are about mental health, about feeling like you can feel comfortable in your body and claim your body and not feel so disconnected. I would love to hear how you define medical benefits, because I think about if you're thinking about the person as a whole, they might identify their wholeness, their whole health feels different than what their A1C looks like or what their blood pressure reading is. So think that that's a really important piece to include. So there's different cases One of the cases is really thinking about how we miss the mental health piece, right? How our clinic runs and how we might misgender someone. It really gets you thinking about different layers to the medical system and how we can be better providers. Hopefully, this is just the beginnings. In New Mexico, there's an organization called the Transgender Resource Center of New Mexico, and they put on these monthly presentations for providers, and they actually train people outside of the state as well. And I just love it. I'll go and attend a couple of those a year just to refresh and think about how I'm speaking and like how am I making my space comfortable. They also offer different community supports. So understanding and recognizing where your resources are important as well as training opportunities. Thank you so much for your questions. This was wonderful.
Thank you so much, Dr. Boland. It was a pleasure hearing about this.
Yeah, you got it. Now take care.